So I just felt like when I went to teach it to the dental students that there had to be a way to make it a little bit more manageable. So hopefully that's what this course will do. I just want to tell you that, warn you that it's a lot of information, but as you use it, it will start to make much more sense to you. Let's go ahead and get started. First of all, I just wanted to set out the just the understanding of why we are going to diagnose perio, which seems so obvious, but I know some of you may be in a practice that doesn't value it and just thinks everyone should get a prophy and a little rubber cut polish and be good. So if that's the case, I'm sorry. But so if we start at, like, say, Maslow's hierarchy of motivation, the very bottom rung would be tell them to that if you happen to work in a practice that is not pushing perio, if they don't diagnose perio, they could go to prison. True story that I have worked with a doctor at the school that I work at, and her father was a dentist and did go to prison for 5 years for not diagnosing perio. So it could happen. It's not the reason we want you to do it, but that's a bottom rung. The next one would be that you will be more productive. If you diagnose perio, you're going to be more productive than just doing prophies. You would give the practitioner, the hygienist, or the dentist that's doing the cleaning the time that they need to be able to do the procedure. I've got to admit some more people. I'm going to go back. Okay, so let's just give you a little bit of a background on the AAP and their classification or diagnosis. We have in 1977, they came out with one. Again, this is just a history for you. So in 86, 89, and then 99 was the one that most practitioners that have been out for a while are familiar with. So we went from 99 to 2017. So it was a while, 18 years before. And this one is not necessarily just the American Academy of Perio. This is an international committee that got together and put this all together. This slide right here, it just kind of goes over an overview of the whole diagnosis. So I kind of took that and made this next slide. Okay. All right, so this is periodontal conditions of the mouth. On the left side of the screen, you'll see Periodontal Health, which will include, I don't know if you're seeing these, but I keep getting these people that are coming in. So on the left side of our screen, we have Periodontal Health, including gingival and perio health. So just your regular, we have all of our CAL, all of our attachment is intact. And then we also could have a patient that has clinical attachment loss for maybe occlusal, or they've had some ortho or bruxism, and they have some attachment loss, but they're still healthy. So we have no pocketing. So that is down here would be considered health on reduced periodontium. Then we have gingivitis. So this is before we get into pockets, right? We have inflammation, we have bleeding. So we have inflammation and bleeding, gingivitis. And so with that reduced periodontium, which could be because they had perio treatment a long time ago, and now the pockets have reduced, but we still have that clinical attachment loss. So that still could be someone with gingivitis. Because they don't have pockets, we don't have to put them over in this periodontitis when we do our initial diagnosis for them. So the periodontitis, again, we've got the necrotizing ANUG, as you maybe heard it before and used it in practice, and then also periodontitis related to a systemic disease. So this could be leukemia, could be AIDS, something like that. And then over on the right-hand side is mucogingival defects, also like perio abscess, so things that are also affect the periodontium, but not necessarily or something we're going to classify or put in our staging grade. So let's go on. Also, just to note that the implants have their own classification. Okay, so this slide is just to make the point of what a full perio chart consists of. And I know that a lot of offices, that when you go in there, you are good to have time to do probing depths. I understand that. I am going to try to show you why it is so important to have your complete perio chart when you're doing this diagnosis. There's other things that you can do. You can do PSRs to check to just screen, and then when you know that you're into a perio case, get all of this information. But a full perio chart really does consist of your probing depth, your free gingival margin, which will then give you your clinical attachment loss, furcations, and mobility. This chart right here is what we use at the dental school. It's Axiom is our software. But out of curiosity, I decided to look up EagleSoft, which is one of the more popular out there. And on EagleSoft, as you can see, you have the option to you have the option to put in your free gingival margin. You even have an option to use your negative and positive numbers. If you click on gingival margin, it will give you the option to do negative and positive, and over a little bit why that's so important. And then also with Dentrix, for some reason my computer's being tricky. All right, so with Dentrix as well, we have the option to put in free gingival margin. It also has a place to put in furcations and mobility. So if you haven't ever used this before, go into your practice and look it up. I do recommend, and we can go over that, but if you're doing a full perio chart, you really need to have an assistant or someone helping you out. If you have an assistant, this full perio chart that I'm going over and talking about can be done in 10 minutes. Okay, so just to review free gingival margin, I don't know how it was for you in school. I don't remember learning this. We probably did, so sorry if my instructors are on this call, but I just don't remember it. We do it at the dental school, and there's really a good reason for it. Recognize that your probing depth combined with your free gingival margin is what's going to give you your clinical attachment loss. So at the school, we are using for normal and healthy mouth a -3, -2, -3, which means that the free gingival margin is 3 millimeters coronal to the CEJ. So the CEJ is considered 0. So if we were going to do a free gingival margin that you looked in their mouth and all of the gingival margin was right at the CEJ, you wouldn't have to put anything in there because it's 0, right? But if they do have papilla, which most of us do, and it's a -3, you need to add -3 on your free gingival margin so that your probing depth will show the appropriate clinical attachment loss. So as you can see right here on this tooth right here, we have a recession, which you would put in as a positive number. So -3, +2, -3. Some of the students might be thinking, because I think I have some of my previous former students on here, that we have done -2 before. But for this classification, it is for clinical attachment loss, not level. And so clinical attachment loss, we put it at a -3. So just, that's what we're going with, -3, -2, -3. Okay, so this is just a quick review because I know this might be something you don't do all the time. So on this top picture, where probing depth is 1, right? But we have a FGM of 5, okay? So our free gingival margin is a +5. Our probing depth is 1. Those combined gives us how much attachment loss, clinical attachment loss. Oh, my light became bad. I've got to change this or you won't be able to see. Okay, back again. So the clinical attachment loss on that case would be 6. So this is just a math problem. You are going to combine the two numbers. So when we have a -3 on a 6 millimeter pocket, so on this one, the probe is in 6 millimeters, but we know that free gingival margin is 3 millimeters from the CEJ. So this is going to be 3 millimeters of attachment loss. Okay, so hopefully you follow that. And the reason that's important is because if we just went with the 6 millimeters, then that would be a much more severe case of periodontal disease. If we assumed that whole 6 millimeter pocket was all attachment loss, that would be a whole different story. Okay, so now what we were going to do after we've got our probing depths, and also you can do it beforehand, but you're going to for sure want to look at a set of x-rays. Now, I know a lot of times in offices you don't do a FMX on everyone, so you may just have a pano bite wings. That's fine, but you want to look for bone loss because it could be that it's pseudopocketing. And if that's the case, then that puts us in a different classification. But this case obviously does have bone loss. All right, so now to get to how we can bring it together. The AAP Perio Diagnosis includes 5 components: extent, stage, grade, host factor, and stable and non-stable. Okay. So just kind of keep that in mind as we go through these. Those are the 5 things we're going to come to. The extent is generalized and localized. It's 30% of teeth. So we're just looking, do we have 30% more of this mouth that is periodontally involved? Then yes, it would be generalized. If it's less, it's localized. The stage is going to be how severe it is, how much loss we have. We're going to use clinical attachment loss for this one, mainly. We look at the other factors as well, but mainly you're going to go with clinical attachment loss for your stage. Your grade is the rate of progression. So how fast is this progressing? And then your host factor is the key ones are going to be smoking and diabetes. There's other ones that we'll talk about. And then stable and unstable basically is bleeding or not. So is this condition stable or not? So again, 30% of teeth, generalized, less is localized. So to give you a guideline, 32 teeth, 10 teeth have to be involved for it to be generalized, 10 or more. 28 teeth, we have to have 8 teeth involved. Okay, so here's our table. Hopefully you got my email that I had you printed out because I think it will help you as we move through the slides to be able to look at this. Again, this is gingivitis here on the left. As you notice, it actually has under gingivitis 0 to 1 millimeter of clinical attachment loss. And you wonder how that could be because gingivitis is not supposed to have clinical attachment loss. And that would just be for those pseudo pockets. And we're trying to do that free gingival margin measurement. As you can see, it's a little bit suggestive, hopefully not subjective. So with that, we've got a little bit of wiggle room to have 1 millimeter of attachment into that gingivitis stage. So we have the clinical attachment, radiographic bone loss. This is telling you what's consistent with each of these stages. But like I said, when we grab the stage, we're going to use the clinical attachment loss as primary. And you're going to give them one stage, and it is going to be the most severe. So if they have one tooth that belongs at 3, then they get a stage 3. Okay? And also, the stage is not going to change unless it gets worse. In other words, if they improve, they still keep that stage. The grade may improve because it's not progressing, but they're going to keep that stage. Okay, so now let's just go through these and let me give you an idea of what they look like. And you probably know this already, but let's just kind of cement it in. So a gingivitis case, like I said, 0 to 1. Now on your probing depths, we've all seen gingivitis that has like 5 millimeters. And if you're certain by looking at your radiographs, and particularly this is going to be a young person, like we're talking early 20s, that comes in and their gum tissue is really inflamed and they may have 5 millimeter pockets and their bone level looks perfect, then they would still be considered gingivitis. Because like I said, we're going for the clinical attachment loss. So you just need to make sure your free gingival margin numbers are appropriate. Radiographic bone loss should be nothing, and the others as well. Okay, so stage 1, periodontitis. Again, probing depths 4 to 5. We're starting to see clinical attachment loss. So on that first stage, it's 1 to 2 millimeters and of clinical attachment loss. All right, stage 2, we've gone to 3 to 4. So we go 1 to 2 in the first stage, 3 to 4 in the second stage, and then you'll see what happens with the next one. And of course, the bone level is getting up. It was under 15 in 1, 15 to 33 in 2. So this is our stage 3, pretty advanced. And this is 5 or more as far as the clinical attachment loss. And I don't know if you remember back on your table or you may be looking at it, your 3 and 4 basically have the exact same as far as what qualifies them. There's a couple of differences, all right? The main one is that they have potential of losing a tooth or two, a few teeth with stage 3. With stage 4, basically they will lose their dentition. I mean, that's the prognosis. Let's see, what else was there? Oh, also with the how many teeth they've lost over time from periodontal disease. Now, a lot of patients don't know that. If they haven't been taking care of their mouth, they just got it out because it hurt. They don't know why they lost it. But if they do, or if you have record of it, if they've lost less than 4, it would be a stage 3. If it's more than 4, then it's a stage 4. So this is our stage 4. Also included is the midway. So also included is the flaring, and we have biting dysfunction. So if you've been in practice long enough, you know what a class 4 looks like. It's right there. So let's go on to our next one. So we've got the stage. We talked about generalized, localized, and we talked about stage 1 through 4. Now we're going to the grading. And this is going to tell us, remember, how fast it's progressing. Now there's 2 ways to get to our grade. We can either do what they call direct, and that's if we happen to have x-rays for the last 5 years and we could compare them, then we could use the direct way, and I'll show you how that is in the table. If you don't have x-rays, which we usually don't have 5 years in the dental school of the same patient, I'd like to think that they all come and we would have that, but not usually the case. So we use a bone level equation, which is right here. This is on this screen, is just showing you how you would take a PA. So this is another point I wanted to make. Oftentimes in offices, you only do panel and bite wings, but I would recommend for teeth that are really periodontally involved to get a PA. You can see the bone level better, and especially for like this calculation, because you need to go from where the bone level should be, which is a couple millimeters below the CEJ, and below I mean apical, to the tip of the root. And so I basically just separated that in thirds to show you, and I'm guessing this one right here at about 33%. So you are going to have to eyeball it, and but that's how we're going to get our equation. I'll show you that. And then you're also going to take in with this grade, with the rate, the smoking and diabetes, if they are smoker or diabetic. Okay, so here's our table for the grading. A being the slowest, C being the most rapid, most severe, right? So you know how I mentioned the direct. So we have no radiographic bone level loss over 5 years would be an A, less than 2 millimeters would be a B, and over 2 millimeters would be a C. Now, if we do the indirect way, we had our x-ray, it showed us 33%. The patient, we're gonna say, is 62 years old. So we're gonna take 33, we're gonna divide it by 62, and it comes to 0.53. So we would put it in here because it's between 0.25 and positive 1. So it would be a B. Now, just to give you just an idea of what that means, if the patient happened to be 25 and had 33% bone loss, they would get, their equation would be a 1.3. So that would take us down to a C. I mean, you can obviously see that if you have someone who's very young and lost bone, it's happening faster than if we have someone who's 80 and lost the same amount of bone. All right, so also I wanted to point out, we have had enough research to show us how smoking and diabetes really affect the periodontium and the body's response to the disease process. So they cannot be a smoker or diabetic and be in that A category. So if they smoke less than 10 cigarettes and they've kept their A1C pretty much under control, under a 7, then they would be a B. If it's over 7, it's a C. Now, some patients will not know their A1C. It's really important that they find that out, and you talk to them about the relationship of diabetes with their immune system and their response, and the direct correlation between perio and diabetes control. So it's going to be hard for them to get their perio under control if their sugar's out of control, and vice versa. All right, now the next section we've gone through, we went through the extent, we went through stage, we went through grading, and now we're talking about the host factor. And like I mentioned already, diabetes and smoking, but also like rheumatoid arthritis has been shown to be connected. There's immunosuppressive conditions as well. The only two right now that are into grading are the diabetes and smoking, but I do think it's important to mark on your chart host factors so that you understand what systemically could be affecting the process. All right, so now we're looking at the stability, which basically is bleeding. And it's considered stable if there is less than 10% bleeding. But the caveat to that is that it also has to have, if they have any pockets that are 5 or more, it's not considered stable, even if it's bleeding or not. So they've got the bleeding stop, but they still got a 5, it's not considered stable. So really the only section in this would be a stage 1, so that they didn't have, and we got the pockets down to 4. I guess in stage 2, if you're really great, you could get them down to 4, but if you didn't have more than 4 and there were no bleeding, then you could get stable, but most, I would say 90% of your diagnoses are going to be not stable. All right, so let's just look at an example and try to figure out what stage just what stage this one would be in. So look at your chart. I'm going to give you just a minute to look at it. I've put on here that this patient is 30-year-old female, non-smoker, non-diabetic. So we don't have to worry about that when we get to the grading. So what I would do first is we get to our extent. So let's look for 1s through 5s on on this chart. And this is easier. I don't know on Gentrex or EagleSoft if they're different colors, but for our students, the attachment level, which is not listed as CAL like it is on yours, which is Gentrex and EagleSoft, ours is listed at this attachment. So right here, attachment. And they're blue. So I always tell the students, look at the blue numbers for our diagnosis, and we're looking for 1s to 5s. If more than 30% are 1 to 5s, then you already know you have a generalized condition, which is definitely the case here. And then we're going to look for a trend. We're going to look for 1s and 2s, because that goes with our stage 1. We're going to look 3s and 4s. That would be our stage 2. And then 5 or more would be either 3 or 4. So let's just kind of look through here and see what we can see. I usually kind of look for the most severe. So I see a 5 here. So I just start counting them. 1, 2, 3, 4, 5, 6, 7, 8, 9. So 10, 11. I'm already up to plenty of teeth to bump me into either a stage 3 or a 4. So let's take a look at the x-rays. So there is a lot of bone loss, but for me, I wouldn't put this at a stage 4, because I still think that we still do have some bone level there. And then so we've gone through the extent, generalized, stage 3, grade. Let's get to our grade. Let's look right here. This has it all out for you. So this right here, we have, again, this one's about at 33% of the tooth that we measured. You try to find the most advanced one to measure, but anyway, so you would take that 33, and this patient was 30 years old, 30-year-old female. We're going to figure that out. And we would figure out what grade she is in, and she is a 1.1 on that equation. So we have generalized stage 3, grade C, no host factors, and unstable because of all the bleeding. Okay, so just here's a review really quick. We have extent, generalized, or localized. We have the stage, which is how severe it is, 1, 2, 3, or 4. We have a grade, A, B, or C, which is how fast it's progressing. We have host factors, which tells us how they're going to respond systemically, and specifically smoking and diabetes, which come into the grading also. And then we have stable or unstable, which basically is how much bleeding there is. So now you got it. All right, so this is our chart that helps us on the staging, and also there we go with our grading. I want to thank you all for coming and for caring enough to want to know more about it. It's been helpful for you. I'm going to click down here and see if I can get to questions. I'm going to let you unmute yourself if you want to ask me a question.
Hi, my name's Betsy. Can you hear me?